All right, we can start now, please.
A 67-year-old male patient from Telangana is admitted with the complaints of dysphagia for the past 2 months. Loss of weight and loss of appetite is also his chief complaints. History of present illness. Patient was apparently all right 2 months back when he noticed difficulty in swallowing solids with a sense of bolus of food stuck at the epigastric region, which gradually increased in severity. He is able to swallow liquids without difficulty. History of weight loss 8 kg in 2 months. History of loss of appetite present. No complaints of dyspepsia, retrosternal burning sensation. No history of pain during swallowing. No history of halitosis. No history of hematemesis. No history of melena. No history of regurgitation. No history of abdominal bar chest pain. No history of altered bowel habits. No history of vomiting or abdominal distension. No history of cough, dyspnea, hemoptysis. No history of fever. No history of icterus, backache. No history of
Ravi,
mass. Sir?
if I interrupt you, you don't
Yes.
have to repeat no history, because the only thing that registers in my mind is no history. Rest everything is not registering. So just say no
Yes.
history of X, 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 and Y. Yeah? So that becomes easy in presentation. Thank you. Thank you.
So sorry, sir. No history of mass per abdomen or palpable swelling elsewhere, and corrosive intake or drug abuse. History of increased frequency of micturition and urgency present. No history of
You say here
hematuria.
drug abuse, Ravi.
Yes, sir.
Dr. Inian, am I allowed to interrupt in the middle?
Yeah, absolutely. I think.
Yeah, so you say there is no history of corrosive or drug abuse. What does
Yes,
this
yes.
mean by drug abuse? How you define drug abuse?
Sorry, if the patient develops withdrawal symptoms once he is without the drug, or he is using the drug for more than 3 months, that is
It is a standard definition of drug abuse. It can be drug dependency also. So the suggestion here is to use chronic intake of a specific drug or something like that. Using abuse is kind of little tricky in examination. Thank you. Move on.
Yes. Past history. Patient is a known hypertensive on medications. No history of any previous surgeries. Personal history. He has adequate sleep. Appetite is reduced. Addictions none. Consumed mixed diet. Bowel habits are normal. Family history. No significant family history. Summary. A 67-year-old male patient is a known hypertensive. Is presented with the complaints of dysphagia and associated with the history of loss of weight and loss of appetite, and associated with increased frequency of micturition, with increased frequency of micturition and urgency. No history of hematuria. My probable diagnosis could be a malignancy of gastroesophageal junction or lower esophagus.
Can you go back to the history slides, please, like the ones that your negative history?
Yes.
So you read out what was given in the slides.
Yes, sir.
So is there anything else you want to ask, Ravi, in addition to what you have just read out on the slides? So this was given to you, but there may be some information that is missing. So
yes,
what is the missing information here?
History of regurgitation, chronic regurgitation, and chronic regurgitation of food. History of voice change.
Okay, good. So voice change is important. Why?
Sir, a malignancy or a lesion in the upper airway, upper esophagus, cervical esophagus, can cause a change in the voice, or involvement of recurrent laryngeal nerve can cause a change in the voice.
Yeah, so essentially it is either direct infiltration or lymph nodes, right?
Yes, sir. Yes, sir.
Infiltration on the recurrent laryngeal nerve, right?
Yes.
So that is one thing. And
yes.
Is there any history of repeated chest infection and things like that? Is that important?
Yes, sir.
Was it given? I don't think it was given, right?
It is not given, sir. If the patient has recurrent episodes of aspiration, patient can go in for recurrent respiratory diagnosis.
Any other reason why a patient with, let's say, a malignancy of the esophagus can have recurrent chest infection? one you said was regurgitation, is it?
Yes, sir. Sir, if the lesion is advanced, patient develops a tracheoesophageal fistula, then he can have a recurrent respiratory condition.
Yeah. So, what other additional history would you get in a patient with, let's say, a malignant tracheoesophageal fistula?
Sir, as soon as patient takes food, the patient will develop respiratory difficulties.
It depends, no? It depends on where the fistula is. If it is
yes.
between the esophagus and peripheral sort of bronchus or parenchyma of the lung, then
he can develop a recurrent.
But if it is between the airway and the main airway and the esophagus, of course, what you said it would be.
Yes, sir.
But more importantly, they present with repeated chest infections, etc.
Yes, yes.
And it is usually aspiration. You said regurgitation, more than regurgitation, like aspiration of the
yes,
thing into the airway, which causes repeated chest infections.
Yes, sir.
Okay, sure. Dr. Azhar, anything else that you want to ask?
No, I think we should just move on. When you summarize, you should summarize in 3 or 4 lines. You don't have to give everything in the negative history. So summary need to be written more crisp, otherwise it's all right. Thank you. Move on.
And just one more, I just want to say here is you said it was the malignant, it is a malignant condition that you're dealing with.
Yes, sir. Yes, sir.
Yeah. But you also located it to the lower esophagus, no? GE junction.
Yes, yes, sir.
Yeah. Why can't it be proximal stomach? So the point is, don't be so, don't narrow it down to so, thing with the history.
Yes, yes.
Keep it broad, keep your this thing open, all right?
Yes.
If you you definitely cannot say this is GE junction tumor based on this.
Yes.
All you can say is it is the malignant dysphagia with a high index of suspicion, right?
Yes. Yes.
Okay, go on.
Physical examination. Patient is conscious, cooperative, and oriented. The BMI is 21.4, height is 1.72 meter, and weight is 62 kg. Well built and well nourished. ECOG performance status of 1, a pulse rate of 73 per minute, blood pressure of 140/90 millimeter of mercury, respiratory rate of 14 per minute. Patient is afebrile, no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema. No signs of malnourishment or dehydration. Oral cavity is normal. Per-abdomen examination. Abdomen is flat, umbilicus in central position and inverted. All quadrants of abdomen move equally with respiration. No scars, visible peristalsis, skin nodules or engorged veins. No fullness or visible lump. Hernial orifices, no visible cough impulse. No renal angle fullness. External genitalia is normal. Palpation. Soft and non-tender. Hernial sites, no palpable impulse, not in hernial sites. Liver and spleen are not palpable. No other palpable lump. Percussion. Liver dullness starts at the upper border of 5th intercostal space. Liver span is 13 centimeter. At flanks, tympanic. Auscultation. Normal bowel sounds heard. No bruit or venosum. Digital rectal examination. Perineal skin normal. Normal skin tone and gloves stained with yellowish stools. Examination of
Ravi,
other. Sir?
What are the important clinical finding in abdomen you can have in patient of GE junction tumors?
Sir, a patient can have periumbilical nodule. Periumbilical nodule if the patient is advanced. If the patient has
you see
liver
periumbilical nodule?
Sir?
How often you see periumbilical nodule in GE junction tumors?
Rare only, sir.
So give us some common findings.
Sir, liver can be palpable, sir.
Why?
If the patient has liver mets, large, which is
liver mets can lead to enlarged liver and palpable liver.
The mets size is large, then it can be palpable.
So you mean to say there is a lump you can palpate?
Yes.
When you say you palpate the liver, that is hepatomegaly. If you say some lump in the liver, that is understandable.
Yes, sir. Lump in the liver.
Anything else?
Sir, deposits in the pouch of Douglas in rectal examination we can see.
Before that, anything more common? Ascites, right?
Yes, sir, ascites.
So when his question is asked like that, common thing should come first. Should have said ascites, then followed by lump in the liver, or maybe pouch of Douglas fullness. Those are in chronology, right?
Yes, sir.
Okay. Over.
Examination of other system, normal, sir. Summary, 67-year-old male
Anything in
patient.
respiratory system, in esophageal or G junction tumor? Any specific thing that you will find or you want to look for?
Sir, if the patient has any Krebs in palpation due to recurrent respiratory tract infection or Krebs due to fistula can be seen.
Okay, what else? Anything more common than Krebs? Effusion, right?
Yes, sir. Pleural effusions can occur in malignant case. Malignant effusion.
So we are talking about malignancy only, right?
Yes, yes, sir.
Okay, move.
Summary, 67-year-old male patient presented with the complaints of dysphagia for the past 2 months associated with the loss of weight and the loss of appetite and sensation of food bolus stuck in
So
the
what is your differential diagnosis? With a case summary of history and examination based on that, what is your differential diagnosis? What is your diagnosis and differentials?
My differential diagnosis could be the carcinoma of lower esophagus or OG junction. OG junction, sir. Carcinoma of lower esophagus and OG junction.
So it is malignant dysphagia, right?
Yes, sir. Yes, sir.
Like Dr. Inian was pointing out, it's very important for you to say a broad diagnosis like dysphagia due to malignancy and the possibility of 1, 2, and the like that. Even it is better to say things like that, but it's better.
Yes.
Any other cause you want to keep in differential? If no, why?
Sir, can't get it.
Any other differential diagnosis apart from malignant dysphagia you want to keep in this case?
Sir, old age patient, other than malignancy, I could not expect, sir, but peptic stricture can also be a finding, but it is rare nowadays. Sir.
So peptic stricture where?
Peptic stricture in the gastroesophageal junction.
Okay. Generally, peptic stricture are not that common, of course, but yeah, if it is a peptic stricture, what is against?
The patient is having loss of weight and loss of appetite are against.
This can happen in long-standing peptic stricture. The only thing is the duration.
Yes, sir. Very
Malignancy
less,
durations are usually in weeks and months, maybe few years.
Yes, sir.
But in peptic stricture, it will be always in years.
Yes, sir.
Do you think this dysphagia is because of dysmotility? Like various esophageal dysmotility causes this kind of symptoms?
Less likely, sir. The patient is not having any other symptoms other than dysphagia, and it is a progressive dysphagia. Patient didn't have any complaints of chest pain.
You know what, Ravi? Even the benign condition, the dysphagia can be progressive. But the only thing that need to understood is the progression is over years, 5 year, 10 year,
Yes.
right?
Yes, sir.
So the duration is very important. Second is weight loss is significant, which is very important. That takes you toward malignant dysphagia. That I totally agree.
Yes.
Dr. Inian.
And for the benefit of the other students here, basically, dysphagia history is important in this patient, particularly when you're suspecting an esophageal cancer. So, Ravi, can you tell us what are the, in terms of the dysphagia, the history that you got, how does dysphagia help in one, obviously you're suspecting a malignancy based on, because that's the only positive finding here, along with weight loss.
Yes.
So what else does it help us to in this patient or in any patient like this? The history of dysphagia, a very detailed history of dysphagia is important, right?
Yes, sir. Yeah. Yes, sir.
So how else does it help? In addition, one is your suspicion of diagnosis. which
Yes,
is what you said. In addition to that, does it help in any other way?
So since the patient has dysphagia, depending upon the nature of dysphagia, we will be able to locate the site, at least as a site of the lesion we can locate.
Yeah, generally it doesn't correspond. Yeah,
Yes, sir.
it's not a very
but even though not accurate, but
yeah. So it could be anywhere above where the site of dysphagia is.
yes,
So more than that, it is a prognosticating index. Okay, a
yes,
patient with severe dysphagia, generally it indicates that one is the tumor is perhaps a little bit more advanced as opposed to this thing. So it
Yes.
helps prognostic. But most importantly, I feel it also helps you to decide on the requirement for additional nutritional sort of
yes, yes, sir.
treatment for this patient.
Yes, sir.
If the patient is dysphagic, then you can actually, more than endoscopy, the history is important. Therefore,
Yes,
you may have to insert a nasogastric tube while you're giving neoadjuvant therapy. So
yes,
it actually helps you to decide the requirement for a tube placement or a enteral nutrition for this patient, particularly when you are going to administer neoadjuvant therapy. So
yes,
that I feel is very important. And you
Yes.
said it is progressive dysphagia.
yes, sir. Yes, sir.
Is there any instance where this patient may have relief of dysphagia? Or can it suddenly become worse? Like Dr. Azhar was saying, usually it is a short duration of time. Is there an instance where suddenly the dysphagia may become worse, or suddenly the dysphagia
Yes,
can become better?
Yes, sir. Sir, if suddenly a football gets obstructed in the lesion, then the dysphagia can become worse suddenly.
Yeah, sure. I think that's right. So basically, a footballer's impaction can sort of alter your history. And
Yes, sir.
secondly, when can it become better? I think most patients say that actually.
Sir, after doing an upper GI scopy, patient may feel symptomatic relief.
Correct. So generally, they have relief of dysphagia after this. So just keep all these in mind when you get a detailed list. Okay, we can move on. I think Dr. Balachander has joined. Good morning, sir.
Good morning, Dr. Balachander.
Yeah, can I ask a question?
Yes, sir.
Yeah, of course.
Yeah. Basically, how do you differentiate between the malignant dysphagia and benign dysphagia?
Sir, malignant dysphagia, patient will have progressive dysphagia. Short duration of symptoms will be present. Patient will have loss of weight and loss of appetite. Patient will have no pain. In benign dysphagia, patient may have pain. It will be long-standing for years together. Patient will have associated symptoms. So we can correlate with the cause of dysphagia.
Why I am asking this question is, see,
Yes.
esophagus and stomach, they are developed from the foregut,
Yes.
embryologically.
Yes.
So basically, the symptoms may overlap
Yes.
between benign and malignant.
Yes.
Understand? Stomach
Yes.
and esophagus symptoms may overlap.
Yes.
So we'll have to find out
Yes.
how esophageal symptoms to be differentiated from the stomach.
Yes.
So what are the other symptoms besides dysphagia these patients may present with? Carcinoma esophagus, you said, no?
Yes, sir.
They may also present with other symptoms.
Yes, sir.
Could you elaborate?
Sir, they can present with change of voice. They can present with bleeding.
Bleeding means where bleeding?
Hematemesis.
What else?
Or some patients even present with melena, sir. Recurrent respiratory infection, recurrent aspiration. Sometimes perforation can also be the presentation.
So, okay. What is odinophagia?
Sir, pain during swallowing is termed as odinophagia.
Okay.
So anyway, we've finished up to the examination part, sir. So we can go on to investigations. Can we? What do you want to do for this patient?
Sir, I will do routine. I will do complete hemogram, renal function test, liver function test with coagulation profile, renal function test with electrolytes. I will do, sir.
So
Maybe I think you have those slides. Can you share those slides?
So basic blood investigations, baseline blood investigations. Sir.
Anything abnormality you think? Any abnormality you are thinking that you will find? Any abnormality in baseline blood tests in this patient?
Yes, sir. Patient may have electrolyte disturbances.
Why he's not vomiting?
It's not vomiting, but patient is having dysphagia, sir. So due to reduced amount of food intake.
So with a patient with dysphagia who is not vomiting, why
Yes,
electrolyte imbalance is something more common. I told you, talk about common things first.
yes, sir.
Anything can happen. Don't worry about those things.
Patient
Common
can have
things.
anemia.
Anemia, right? Anemia. Patient can have anemia. Possibility.
Yes, sir. Yes, sir.
Okay. What else?
Patient can have reduced albumin level.
Yeah, reduce albumin level.
Yes, sir.
What else?
Due
What
to
are the
dehydration.
signs of malnutrition
Yes, sir.
you can get during your routine blood tests? One is low hemoglobin, low albumin.
Patient with dehydration and elevated urea levels.
What?
Due to prolonged dehydration. Due to prolonged dehydration, patient can have elevated urea levels.
Urea level. Okay.
Yes.
What are the other nutritional markers that you do in routine blood tests 24/7 in your ward? What are those among those blood investigation can be a marker of malnutrition?
Sir, usually
Albumin, you
long-term
said?
malnutrition is assessed by albumin levels, sir.
No, there are PT-INR you do, that is an indirect marker of synthetic function. Platelet count is an indirect marker of liver function. So these all are basic tests that you can help you find out malnutrition.
Yes.
So meanwhile, your slides are not opening. You tell us,
Yes.
is albumin level a marker of malnutrition?
Yes, sir. Albumin level is a marker of malnutrition, sir. Albumin level is a marker of chronic malnutrition. Yes, sir.
So it's a marker of chronic malnutrition. So what?
Yes, sir.
Why it is said not is a marker of acute malnutrition? Why it is said it's not a marker of acute malnutrition?
Sir, the half-life of albumin is 20 days, sir. So any condition over 20 days only will present with 20 days or more, almost at least 6 weeks malnutrition only will present with reduced albumin level.
So because it is not completely correct what you said, what is important that albumin is an acute phase reactant, right? So whenever there is active inflammation, even a patient with fever, if you take albumin, it is going to be low. So when you talk about albumin as a marker of malnutrition, you should always have to say that albumin in combination with nutrition specific questionnaire like low appetite, not eating, weight loss is a more reliable marker of chronic malnutrition that only compared to only serum albumin alone. Understand?
Yes. Yes.
Yeah, move on with your slides.
So blood investigations are essentially normal.
Yes, sir. Normal blood investigation.
So what next? What do you want to do?
Sir, I will do an upper GI endoscopy to evaluate the cause of dysphagia.
Upper GI endoscopy or barium swallow?
Upper GI endoscopy.
So when you choose barium swallow as a first investigation?
Sir, if the patient is presented with a history of corrosive injury or
No, the answer is, let me quickly answer it. If it is benign looking or
Yes, sir.
motility related, you can proceed with barium. Otherwise,
Barium.
if it is malignant looking, go for
then I'll do
endoscopy.
upper G endoscopy. Yes, sir.
Yeah, move on.
Just one more
Uh,
thing is,
Yeah.
so if
Yeah.
in your history you suspect a vacuoesophageal fistula,
Yes, sir.
that can, be another indication to do
Yeah.
a study. Okay.
So if there is a
Actually-
tracheoesophageal fistula and you want to do swallow study,
Yes, sir.
what kind of dye you will use?
Sir, I'll use a thin barium contrast to evaluate tracheostomy.
Why not gastrographin?
Sir, gastrogavin can cause severe chemical pneumonitis, leading to.
Why?
Sir, it is a hyperosmolar agent, sir. It can suck out all the water. It can absorb all the
Yeah,
water
so
from.
it is hygroscopic, lead to a hyperosmotic
Yes,
pneumonia. So in
Yes.
what is the problem when you give barium?
sir, barium will stay longer in the tracts. So it can.
And second, if it is leaking into the mediastinum, what will happen?
Then it can lead to mediastinum.
Severe
If there is a
mediastinum,
perforation, we should
right.
not use barium.
So you should always say thin barium, right? Because
Yes.
if thick barium, it stays there, subsequent CT scan and imaging will become difficult.
Difficult. Yes.
Yeah.
See, barium studies is also indicated. Supposing the center does not have the facility of upper G endoscopy.
Yes.
So that is one. If the patient has a long-standing stricture, the long strictures,
Yes.
then if you want to see the distal end of the disease,
Yes.
no. So sometimes barium can give an information, but
Yes.
otherwise the gold standard is the upper J endoscopy.
For
Yeah.
endoscopy. Yes.
So these are the findings. These are the findings. So
Also, no.
what are you going to do now? What is the advantage of upper J endoscopy?
Sir, we can
What
exactly
things you will
locate.
see? What things you will see?
I can exactly locate the size of a lesion, site of the lesion, sir. How much centimeter from incisors it is, and anatomic location can be exactly delineated. I can get a biopsy of the lesion. I can check whether whether I'm able to pass the scope beyond or not. I can check for any other coexisting lesions in the esophagus or stomach.
Suppose you are unable to pass the scope. Would
Yes.
you dilate or not?
Won't dilate, sir. Malignancy not needed. Dilatation is not needed unless the
Why?
palliative. Sir, if I am planning for a curative management, I won't dilate. There is increased chances
Otherwise
of
also?
perforation. Increased chances of perforation.
Yeah.
Yes, you should not dilate.
Yeah. You should not.
Yes, sir.
So
Okay.
this is the endoscopy report, Ravi, right?
Yes,
Is
sir.
it the information complete here?
Sir, how much centimeter from the incisors is not mentioned, sir.
Okay. That I don't want to know that as well. I want to know something else.
Sir, how
When
much?
it is in G junction. It
Yes,
is
sir. How
near
much
the G
extension
junction.
into stomach, whether it is extension into the lesser curvature or into the greater curvature into the stomach in it.
So although I think we are going to discuss in time to come that about severe type 1, type 2, type 3 about the centimeter from gastroesophageal junction. Those informations are generally lacking in most of the endoscopies. We do not know where is the G junction, how proximal the tumor is from G junction, how distal is from G junction, right?
Yes, sir.
Right. Okay. Next.
Next, I would like to do a contrast enhanced CT of the chest and
No, you
abdomen.
are not
And
talking. You don't take biopsy.
yes, sir.
Go to the next slide. They have done a biopsy.
For well differentiated squamous cell carcinoma.
So, what is the trick of doing biopsy with upper G endoscopy? What is general recommendation?
Sir, we have to take 6 to 8 biopsy using the standard biopsy forceps from the edge of the lesions.
From the non-necrotic part of the tumor.
Yes, sir.
Okay. So if the biopsy come negative, in case like this, you do upper G endoscopy, you took 6 biopsies,
Yes,
and still the biopsy come negative, what would you do?
Sir, I'll opt for an repeat biopsy, or I'll opt for a well biopsy.
Oh, what?
Well biopsy. Well biopsy.
Well biopsy.
Yes, sir.
Anything else you would do in next time when you go for biopsy apart from well biopsy means good bite on bite, basically deep biopsies.
Yes, sir. Deep biopsy.
So anything else that you would love to do now this time so that the yield something comes out?
Sir, if the lesion is not if the lesion is visualized, I'll do well biopsy only, sir. If the lesion is not visualized or difficult to visualize at a stricturous growth, then I'll plan for dilatation and biopsy.
No, dilatation is not done. There are some enhanced endoscopy coming. It's already in practice, like narrowband imaging,
Narrowband imaging,
endoscopy.
optical coherence. Yes.
So optical coherence tomography is not right now required. What kind of endoscopy you will do? Narrowband imaging or what is that called? What is that other thing is? One is narrowband imaging, chromoendoscopy.
Chromoendoscopy.
What will you
Sir,
choose?
Sir, narrowband imaging I'll choose.
So whenever there is mucosa is intact and there is irregularity,
Yes.
that is narrowband imaging is
Narrowband
helpful.
imaging. Yes.
But whenever there is ulceration or elevated
Ulcerative lesion,
lesions,
then I'll use chromoendoscopy.
right?
Yes, sir.
Okay. Now you took the biopsy, it is squamous cell cancer.
Yes, sir.
Move on.
Sir, I'll do a contrast and CT of the chest and abdomen in this patient.
My resident would do an ultrasound and they show multiple liver nodules and ascites.
Yes,
You said you want to do a CT scan.
yes, sir.
My resident did an ultrasound and he found multiple liver nodule and ascites. So you over investigated the patient. Patient is asking, doctor, why you're spending my money?
Yes, sir. Ultrasound, I'll do first investigation.
Why ultrasound? Why
Sir,
yeah.
Sir, if the patient has bilobar liver mets,
If it is unilobar?
or yes, sir, liver mets. Sorry, sir. If the patient has liver mets or ascites.
So no, we just quickly go, Ravi. Whenever things like that happens, it is easy to defend doing ultrasound than not to do an ultrasound in the part of routine investigation. So you can always say the extension of clinical examination. It is readily available, cheap. It is the lesion around the G junction. We might get some metastatic finding which can change everything.
Yes, sir.
So doing an ultrasound is not over treatment, but not doing an ultrasound, you can be in multiple different questions by different examiners. That's what I was saying. Okay, ultrasound is done. Is normal. Next.
Then I'll this patient has an right VUJ calculus.
It's not important. It will be taken care of. We have urologists. Move on.
I'll do a contrast and CT of the chest and abdomen for this patient.
Okay. Why CT scan? Why not PET CT scan?
Sir, if the institution has a PET CT scan, I can do a PET CT preferably, sir. But PET CT has its disadvantages. PET CT has its disadvantages.
I have to interrupt you again. Can should not be used. You cannot.
Yeah.
Because
the
you're
first
the
choice
patient.
image.
Yeah.
First
You cannot say I can
be,
do this, I can do that. You have to choose something need to be done with a rationale behind it.
The first,
So I asked, you said CT, I asked why not PET CT? So I agree with you. CTs can defend it.
Yes, sir. The cross-sectional studies will accurately are thin sliced, sir. Whereas PET CT, most of them are thicker slices.
No, we have thin slice PET CT in your center also. They have thin slice PET CT scan. That is not the answer.
Yes, sir. It's most costly.
So
sir,
what will you see in the CT? Let us discuss what will you see in the CT. Why do you want to do CT?
The lesion.
Why do you want to do CT?
So the exact lesion, site of a lesion can be.
You want to stage the disease, say like
Yes.
that.
Yes, sir.
You want to stage the disease.
Yes, sir.
So what are the three elements here? T, N, and M.
NM. Yes, sir.
So what is T?
Sir, the local extent of the tumor, sir. Exact site
So-
and local infiltration and involvement of the tumor.
Yes.
Yes, sir.
So then N means?
And nodes around the esophagus and in the abdomen, you see the presence of parietic node or celiac nodes, nodes present in the esophagus, you can see, sir.
M?
M, liver mets and ascites
No.
and lung mets.
Yeah, now we study the CT.
Just if I may interrupt. So Ravi, you have not answered the question that Azhar asked. So if in a ideal situation, a PET CT is right.
Yes.
What are the advantages of a PET CT compared to a CT scan? It certainly would upstage the disease in roughly about 15 to 20% of patients.
Yes.
So what you think as, let's say, operable or locally advanced disease may become metastatic if you do a PET CT scan. So it actually does upstage the disease in up to about 20% of patients, about 1/5 of patients. A PET CT scan can upstage. However, as you said rightly, it may not be available in cost, etc. And in our country, TB is a issue where you can pick up false negative. Let's say a node, a distant node, which is picked up on a PET CT, may alter your diagnosis and treatment. So therefore, you have to chase that node, find out what the node is, and then treat it accordingly. So that is one of the disadvantages of a PET. So basically, but still, even in many centers in India, it is advocated to do a PET CT as a staging investigation.
Yeah.
So
So only thing is, Ravi, if you look at the NCCN guideline, there is a very beautiful word they use. CT scan chest and abdomen as an initial staging modality. And subsequently, if required, PET CT scan they consider as a modality of choice for metastatic workup.
Yes.
So in esophageal cancer, because the curative treatments are morbid, before considering any curative option treatment, a metastatic workup using PET CT scan completes the complete staging workup.
Yes.
Okay. So we can move on because of want of time. So can we?
Yeah, what do you see?
So you have. Can you scroll down or?
Ravi, you have controls.
Sir, I could not scroll, sir. Yes.
So you know the location of the tumor based on the endoscopy, right?
Yes.
So where is it, location-wise?
OG Junction, sir. It is the OG Junction.
Lower third and
Yes,
the junction.
Yes.
And the esophagus is divided into different sections, right? You've got the cervical esophagus.
Yes, sir. Cervical, mid thoracic, lower thoracic.
This is in the lower third of the thoracic esophagus.
Thoracic esophagus.
So you want to scroll down quickly and show us, or?
Yes, sir.
Ganesh can do it because I don't think he's got.
Sir, lesion is in the lower esophagus with extension to stomach, sir. With extension to
You see,
lesser
lower
curvature.
esophagus will become very big.
Yes, sir. Tumor of the gastroesophageal junction, sir.
Can you point out?
Yes.
Can you use a pointer and show where is the growth?
Yes, sir. Yes, sir.
When you say it is intra-abdominal esophagus,
Yes.
because as Dr. Inian said, thoracic esophagus is divided into three parts. Okay, upper thoracic, middle thoracic, and lower thoracic. When you talk about G junction, it generally talk about the intra-abdominal part of esophagus.
Yes, sir.
And then can go into the lower thoracic.
Yes, sir.
So when you say it is abdominal part of esophagus has begun in CT scan.
Yes, sir.
When? What are the landmarks?
Sir, once the lesion crosses the crura of diaphragm, then we can tell it is the lower abdominal esophagus.
So go up a little, scroll up a little, up a little, up. So down. You see the crura now. See the crura. Now it is going
Yes,
down.
sir.
So
Now I am
basically,
seeing
it is
the
rising from the lowermost intrathoracic esophagus, going toward the abdominal
going
esophagus,
into the
and
abdomen.
ending into the cardia.
Yes.
So based on this, Ravi, what is your T stage? You're looking at the tumor. You're looking at the CT scan.
Yes, sir.
What is the T stage of this?
Sir, it could be T3, sir.
What is T3 on CT scan?
Peri-esophageal involvement, involving the adventitia is T3. Sir.
Okay. If you look at the current, most recent Japanese guideline which has come out very recent,
Yes.
T3 is divided into two, right?
Yes.
What are the two?
Not correct.
So it's divided into T3R and T3BR, which is T3 resectable and T3 borderline resectable.
Yes.
So when you say it is T3 and it is suspicious, let's say, do you think it is borderline resectable, this one, or is it, in other words, if you think you can do an R0 resection, it is T3R. If you think it is not possible, then it becomes T3BR, or borderline resectable. So here, the main structure that you would concentrate is what? The aorta, right?
Yes, sir, aorta.
Okay. Well, just tell us about.
But there appears to be a fat plane between the aorta and the tumor, sir.
What is the angle called that you are looking for?
The Ficus angle. Ficus angle.
Okay.
If it is more than 90 degrees, then resection cannot be contemplated.
Yeah, so less than 90 to 110, and then more than 110. There are three.
Just hold on in the image here. If you see, the left crust is very close to the tumor.
Yes.
Do you think it is infiltrated?
Yes, sir, it could be infiltrated.
Why not T4? Anyway, radiological investigations are debated and discussed. We are not sure. We are 80% accurate. So it is okay to say T3 or T4. You said didn't talk about lymph nodal status and other things. So what Dr. Balachander said that you have to talk about T and then M.
Yes.
So what is your clinical stage?
Sir, T3N plus M0, sir.
N plus, why you say N plus? Which one is a positive node you saw? Show me. When you say N plus is positive node.
Peri-esophageal nodes are present, sir.
Where?
And
Show me.
perigastric nodes are also present.
So first is in CT scan, what are the nodes very highly suspicious that it is possibly positive? One is possibly, the word should be possibly. The second is, what are the criteria? Then you can say N positive.
Sir, if the node is more than 1 centimeter, if the node is more irregular, heterogeneously enhancing on contrast, the short to length ratio more than 0.67.
As
No,
rightly
do
Dr.
you
Inian said that,
use the, do you use the criteria of nodes should be more than 1 centimeter? If supposing if less than that, do you think there may not be METs?
Sir, no, sir. If any of the criteria is fulfilled, we have to suspect that has met.
But that nodes in cervical and retrocrural areas, if it could be 0.5 millimeters or 0.6 millimeters, they could be positive.
Yes.
It could be less than 1 centimeter. These are the exceptions. You understand?
Yes.
The cervical and retrocrural nodes, which is less than 1 centimeter, could harbor a metastatic deposit.
Yes.
Not essentially you say the criteria is more than 1 centimeter. You understand?
Yes.
Yeah. Carry on.
Okay, so assuming that, so it's a locally advanced disease, based
Yes, sir.
on CT scan. And what next?
Sir, I'll do a uh, I'll do a PET CT, sir, for this patient.
Why PET CT?
Sir, since the patient
Completely stage the disease, metastatic workup, PET CT scan is indicated as per the guideline. You can say that. Okay, move on to PET CT scan, please. In CT scan, generally the diagnosis, what you would say that T32 whatever and NX MX. That is a better diagnosis to say. And when you do a PET CT scan, you can then go toward clinical T this, M this, and N this maybe. Okay, move on. So just tell us the finding.
heterogeneously enhanced.
So, okay, based on the impression on PET CT scan, I feel, Renin, I'm reading for Ravi that it is possibly T3 oblique T4, NX M0,
Yes, sir.
right?
Yes, sir.
What will you do?
Sir, I'll opt for a neoadjuvant therapy in the form of chemo radiation in this patient.
And the first cycle of neoadjuvant chemoradiation you gave, the patient went into ICU and developed chest sepsis, and he's kind of thriving now. No, thriving for life means something you should have started before that.
So basically, all these patients need to be discussed in a multidisciplinary setting.
Yes, sir.
So, which you have to say, all right. So you need to also make sure his nutrition is okay.
Yes. So multidisciplinary for G junction, esophagus, and stomach is not only chemotherapists, radiotherapists, and surgeons, they are nutritionists as well. So you should start some sort of active or passive rehabilitation to the patient before you start anything. Okay.
Okay. Can I ask one? What is
Yes,
the role of staging laparoscopy in this patient?
Sir, in squamous cell carcinoma, once we do PET CT, diagnostic laparoscopy is always not mandatory. But if the imaging has suspicion, the PET CT has suspicion, then we can do a staging laparoscopy and analysis cytology. Then we can do a FJ or gastrostomy in the same setting.
So you would or you would not do a staging lab for this patient?
Sir, in this case,
you can say yes, no, quickly because we are running short.
Yes, sir. Yes, sir. I can do, sir.
Suppose this was an adenocarcinoma.
Adenocarcinoma, then definitely I would consider doing.
So I think it's debatable for squamous cell carcinomas.
Yes.
Even in adenocarcinomas, if it's a Sieverts 1, then still there is no indication to do it. If it's Sieverts 2 or 3, definitely yes. So staging lab for stomach cancers and for G junction cancers, Sieverts 2 and 3, definitely yes. Okay. But squamous cell carcinomas, perhaps, unless a significant part of the stomach is involved or there is any suspicion, you wouldn't do it regularly.
What is the issue with staging laparoscopy, Ravi? Like staging laparoscopy, you understand it is not that the before surgery procedure, it is a diagnostic procedure, a specific diagnostic procedure before you plan treatment for the patient. And the yield is significant. It is shown as high as 30 to 50%, it can change the management.
Yes, sir.
So what is the shortcoming with this technology, with technique?
Sir, patient may need general anesthesia.
So it is not a patient-friendly thing, and it is not sometimes applicable to various center.
Yes,
That is what the thing is. Otherwise, it is a very good modality. This is the only way you can find out smaller nodules, subdiaphragmatic nodules. There is no other investigation known. Okay, move on. What chemoradiation you give? What neoadjuvant you give?
I'll do I'll do chemoradiation according to cross protocol, sir.
Why chemoradiation, not chemo only?
Sir, for
Why not
squamous cell
flot?
carcinoma.
Before that, can I ask you one question? Why do you
Yes.
want to choose neoadjuvant therapy. What is the advantages? You have
Sir,
chosen neoadjuvant.
yes, sir, yes, sir.
What is the advantage?
Sir, higher neoadjuvant has shown to have improve the overall survival, higher rates
No,
of
no, start from the beginning. Overall, you want to downstage the disease. What else?
downstage.
What about the local control?
Yes, sir. It also improves the local control.
Improves the,
facility. Improve
what
R0,
about the recurrence?
reduces recurrence rates.
R0 resection.
Improves R0 resection and reduces improves our overall survival also.
Yeah, that's correct. So that is, you should know that what are the advantages. Then you go ahead.
Yes.
So neoadjuvant, which neoadjuvant you will choose?
What?
Sir,
Just mention
Yeah.
what are the different neoadjuvant therapies available?
carboplatin, paclitaxel.
No. So basically, in a squamous cell, you are dealing with a squamous cell carcinoma esophagus, right? So
Yes, sir.
tell us the neoadjuvant. We don't want the actual drugs actually, but what are the regimes?
According to cross protocol, we
Cross is what? NACRT.
yes, sir.
What is the other option?
Sir, we can give 5-fluorouracil plus cisplatin, which is previously given.
So chemotherapy alone, correct? So
Yes, sir.
between both the options, what would you choose and why?
Sir, I'll give carboplatin and paclitaxel.
Wait,
Cross
you're saying
protocol.
cross protocol?
Cross
But
protocol.
you know, Ravi,
Right.
cross protocol talked about around 70% of adenocarcinoma.
Sir?
In cross protocol, the cohort of patients were around 70% were adenocarcinoma.
Yes, sir. Cross protocol can be also given in patients with adenocarcinoma, sir.
No, I'm not saying that. Then you still choose cross protocol for squamous. Why? Because in subgroup analysis in the squamous group, the results were more profound than the adeno.
Yes, sir.
That is why, despite having maximum cohort of adeno in cross,
Yes, sir.
still cross is more suitable for squamous cell cancers. Okay, move on. So you give cross therapy. What will you do? How many? Okay.
Just one more thing.
Yeah, please.
Is there any instance where you would choose chemotherapy rather than cross regime? Squamous cell. I'm talking squamous cell.
Sir, if the patient has T4, if the patient has any involvement with the trachea or doubtful involvement with trachea or bronchus or vertebra, then I'll plan for
Vertebra, what is the problem? No problem. The main important problem is something else. Aorta.
Then I'll plan for only chemotherapy, sir. I won't contemplate radiation.
Basically, you're talking about inoperable disease, metastatic disease, correct? So that is systemic therapy. Suppose if it is operable disease, like this patient of yours, when would you decide, or is there any time when you would choose chemotherapy alone rather than chemo-RT? I'm talking about operable, locally advanced disease, not metastatic.
If the patient has severe lung fibrosis or
all that is the general condition, but yeah, so what specifically I'm alluding to is if you radiate the stomach, particularly the fundus of the stomach, that is the most distal part of your anastomosis and going to go in the neck, right? So radiating that and pulling it in the neck is not a good idea. So if you have a squamous cell carcinoma, which goes into the stomach, perhaps involving more of the stomach, and that is one of the relative indications where you may want to avoid. If you're giving RT, you will need to plan the RT in such a way that the fundus is spared. Okay, only if you can do that, it is better to give chemo RT. Otherwise, it may be actually better to just give the patient chemotherapy and operate. Although what you're saying is right. Although
long segment involvement
is better for squamous cell carcinomas.
Long segment involvement of bronchus or the main aorta. sometimes is a relative contraindication of giving RT because that leads to kind of visualization or injury to the radiation. Move on. So you gave chemo radiation. What will you do now? It is finished. Cross protocol, we all know how many weeks it is done. So it is finished. What will you do now?
Wait for 6 weeks, and then assess the response for this therapy.
Oh.
I'll again do a PET CT for this patient.
What is the basic principle of restaging modality? How you choose a restaging investigation?
Sir, if the patient has a local control and the size of the lesion is reduced.
No. What the principle of choosing restaging is the same which we have done pre-treatment staging. One. This is the best way to compare. If you have used PET CT scan before, use a PET CT scan subsequently. It helps you to have a better identification. And when will you do restaging? How many weeks?
6 weeks. 4 to 6
You hear me?
weeks. 4 to 6
4
weeks.
to 6 weeks. Why 6 weeks? Then when will you operate?
Sir, once I do the imaging and I think the patient has responded, or even if without any metastatic disease, then I will plan for.
So basically, when you're choosing restaging modality, there are two things that you need to be considered. If you do early restaging, you might not see the complete response. So this is what surgeons don't want. Surgeon want staging somewhere little later, maybe 4 weeks. But in medical oncologist point of view, they want early restaging that if the disease has progressed, they might switch on to second line. So there is always pros and cons of early and late restaging, but generally it is done by 4 weeks in most of the center. Anything if Dr. Inian want to add?
Yeah,
No,
sure.
Dr.
So basically, you would restage after 4 weeks, perhaps, and plan for surgery. Usually we wait for about 4 weeks, and the ideal time to do surgery again is about 4 to 6 weeks.
So what is the right time to operate, Ravi? 8 weeks, before 8 weeks, or after 8 weeks?
Before 8 weeks.
Yeah.
Yes, before 8 weeks.
Voice is not coming.
Yeah, it's not audible.
Sir, before 8 weeks, sir.
Before 8 weeks. Do you have any evidence to support that?
Sir, if the patient is operated after 8 weeks, the radiation effect will attain a peak in 8 to 12 weeks, sir. Then it will then the tumor will again grow, sir. It has been shown in studies that
This is not true. This is not true.
Supposing you have given the, excuse me,
Yeah.
supposing you have restaged the patient, a PET CT, an endoscopy, you don't find any tumor left. Understand? There is a scar in the esophagus on endoscopy, and you don't see any tumor at all in PET CT. What will be your next step? Will you operate this patient or observe?
sir, if I have given 23 cycles of RT,
Answer specifically to the question, Ravi. Basically, if there is a complete clinical response, is what sir is asking. There is no tumor on CT scan or PET CT scan.
I'll do surgery, sir. I'll tell the patient that.
Supposing I'm giving another hint. If the patient is young, fit,
Yes, then I'll
young means, I mean, fit.
Then I'll definitely do surgery for them.
Why?
Sir, chemo, RT for definitive RT and neoadjuvant RT are different, sir. For definite RT, the therapy is 23 cycles, and for that is 41 gray, and for definite RT, it is 50.4 gray, sir. So if I give
definitive CRT is given to those patients who are elderly, whom you do not want to do any surgery at all. You understand, no? Their plan is complete. You don't want to operate them. But
so
this situation, you are given neoadjuvant, and then you see there is a complete clinical response. So would you take the patient for surgery, or would you wait?
I'll take the patient for surgery.
Surgery. Why? Because they found, there are studies in the literature, they found that even if there is a scar in the, where the CA carcinoma was there, they have taken biopsies.
Yes.
And they found there were the dysplastic changes still left behind, and cancer cells were there. So they advocate that a definitive surgery should be done in these patients. There are a lot of debates. If you go into the literature, a lot of controversies and debates. But ultimately, they say, but if a patient is very elderly,
Yes, sir. Then I
I
will
mean,
consider
that patient, if there is a complete clinical response, you can wait and watch elderly patients. You need not, because their maybe ECOG score may be 2, 3, or comorbidities. Why to subject them? You can watch. Okay, you have contemplated to go ahead with surgery for one-time time. So you are doing resection. What type of resection you want to do it? What is the type of lymphadenectomy you want to choose? We're running short of times.
sir, I'll do an
This is squamous cell carcinoma,
yes, sir.
So what's your plan? Resection. Plan of resection?
I'll do a esophageectomy, either minimally invasive or open approach, and anastomosis in the neck, cervical anastomosis using a gastric conduit. With the lymphadenectomy, two-field lymphadenectomy, sir, abdomen and infracranial lymphadenectomy. I'll do, sir.
So basically, you're talking about a McEwen's operation, correct?
McEwen surgery.
With a two-field infracranial lymphadenectomy.
Yes, sir.
What you should, this is again theoretic. You should know the theory behind what you're saying also.
Yes, sir.
So, what is the chance of let's say a supracranial lymph node or a lymph node in the neck being involved in a lower third esophageal cancer?
Squamous cell carcinoma involve the nodes also. 10% of
You're not audible.
squamous cell carcinoma.
So, for the benefit of the others, basically, if you have a lower third esophageal cancer, still there is a chance of neck nodes, particularly recurrent nodes, being involved. So the current recommendation is to do a complete thoracic lymphadenectomy, a supracranial or a complete two-field lymphadenectomy.
Right.
Whether you add the third field is actually the question. The third field
Yes.
being the neck.
Neck,
So
yes, sir.
then you have to tell the pros and cons of doing the third field. But
Yes, sir.
the advantage right now is minimal. So
Yes.
essentially, complete two-field lymphadenectomy, thoracic lymphadenectomy, seems to be the what is advocated as a treatment modality for squamous cell carcinomas after you give neoadjuvant chemoradiotherapy.
Yes, sir.
Okay, you have done a lymphadenectomy resection.
Yes, sir.
How are you going to, what conduit you will choose for
Sir, I will
anastomosis?
choose the gastric conduit, sir.
Why?
Sir, gastric conduit, single anastomosis, sir. Technically easy. Then
What is the advantage of stomach and what is the disadvantage of stomach?
the stomach is highly vascular, so blood supply is reliable. The patient will have a single anastomosis for the surgeon, so it is technically easy.
Disadvantage?
Disadvantage, stomach is prone for reflex symptoms in the patient, sir. More
Aspiration.
symptoms of reflex and aspiration can occur in gastric conduit. Long-term stricture can also occur in gastric conduit patients.
Yeah. So I think we'll probably need to sort of wind up. So basically, the case that was discussed was a lower third G junction squamous cell carcinoma.
Yes.
And essentially, the staging modalities we had discussed, the neoadjuvant therapy. One question that you did not answer, Ravi, is what is the indication or when would you select neoadjuvant therapy? Anything more than T2 or any node
So I
positive
will do
is
then,
indication for neoadjuvant therapy. And then we also discussed about the complete response. There are trials, again, Ravi, which tell you about the Sano trial is an important landmark trial, which you should know of, which
yes.
looked at in very much in detail about the complete response and how to deal with them. And it is still ongoing. We have still not reached the stage where we can actually predict clinical response completely. In other words, we cannot be sure that there is no tumor. So that is one of the things. The second issue is the intense follow-up that is required may not be suitable for our patients. So like what Dr. Balachander was saying, if in this patient, a young patient, we would still go ahead with surgery. You should be able to tell that. And of course, we discussed the different surgical options. So Dr. Azhar, you want to?
No, I think we just completed it. If you want to, Ravi, if you want to ask anything, please ask.
Yes. Yes.
If you want to ask anything.
Yes, sir.
Dr. Shastri is also here. Sir, any comments, sir?
Not really. I think it's well covered. I think he needs a little more confidence in answering, although he managed to answer, but the confidence and the tone is a little lacking. I think he has to practice that. Otherwise, I think by and large, it's fine.
Sure, sir. Dr. Balachander, sir, any comments?
I think he has fairly answered well, but I think he has to, when you answer Dr. Ravi, you have to answer it
Yes, sir.
without nagging, no? I was watching you,
Yes,
you are
sir.
a little bit nagging and prolonging, no? That
Yes.
kind of thing, it should be crisp. You should present the points twice, no?
Yes.
For example, I asked you stomach, you are just dilly-dallying, saying like that.
Yes.
Confidently, it should come out, in punches, 1, 2,
Yes.
3, like that.
Yes, sir.
Understand, no? Otherwise, you're able to answer, of course, but it was good. But then you have to improve a little
Yes.
in your answering style.
Yes, sir.
I also feel the same thing, Ravi. Just
Yes.
before we just finally wind up, there are just a few questions in the chat box. How do you define Sievert's type on imaging? Do we decide the tumor epicenter? I think, Dr. Azhar, do you want to just take that question? Basically, Sievert's
only
type.
thing I could say that this is a debate and this will remain a debate. There are various ways to define. For example, if I choose endoscopy, and if there is a G junction tumor, that endoscopic morphology is distorted. Now we do not know where is the G junction. So in clinical practice, we define it where the tube opens into the stomach based on the cross-sectional imaging. And based on that, the major bulk we choose, and based on that, we decide what kind of G junction tumor it is. And overall accuracy will be close to about 80 to 85%, no more than that.
Yeah. Then how do we manage esophageal carcinoma post neoadjuvant chemotherapy with partial response and radiation-induced tracheoesophageal fistula? I think once you have a tracheoesophageal fistula, then it becomes palliative. But here, you need to be very sure that it is a radiation-induced and not this thing, but not a progression of malignancy. Perhaps stenting is what may be done in this patient. The third question is for adenocarcinoma, should we do a standard two-field or a total two-field? Does it change per location? This is from Dr. Raviraj. Azhar, do you want to take it or shall I?
Please, please, go ahead.
So for adenocarcinomas, essentially, if you're doing an Ivor Lewis, subcarinal lymphadenectomy, up to that, everybody will do. But beyond that, would you do it? Is is the actual question I think you are asking. If you're doing an Ivor Lewis, to completely clear the left and right recurrent laryngeal lymph nodes, in other words, to do a total two-field lymphadenectomy, the supracranial part is technically difficult. However, that is what one should aim to do, because again, the same, like what we had discussed, a lower third adenocarcinoma can still have nodes in the recurrent laryngeal shape. So the aim is to do it, but it is definitely, in terms of the technically, it is definitely technically challenging. But for squamous cells, definitely you need to do it.
Yeah. For adeno, basically, you would prefer not to do it. But for squamous, generally, I would not prefer to do an Ivor Lewis. Generally, my take is for squamous, I will not prefer to do an Ivor Lewis. I will rather do total mediastinal lymph node and total esophagectomy. For adeno, where grossly there is no supraesophageal, supracranial nodes and imaging, I will do it the classical two-field lymph node dissection, Ivor Lewis for adeno.
Then Dr. Santosh Subramaniam is asked, a 56-year-old gentleman, ECOG 0, lower esophageal cancer, perforation during an OGD biopsy, was given Folfox 6 cycles. NACT, PET CT showed activity in the lower, this is after the post NACT. PET CT showed activity in the lower esophagus and in the pylorus with thickening of 4 centimeter and SUV of 9. Basically, there is activity in the pylorus also now. So the question is how to manage and the conduit of choice. Okay. So here, I guess the issue here is one, a perforated tumor obviously has got, the prognosis is bad. Now here there is also some activity in the pylorus, which was, I guess it was not there initially, and now there is. So one needs to make sure what it actually is. It is unlikely that it was missed in the primary thing. But if the stomach is also involved, then you will have to look at an alternative conduit, providing everything else is okay. So I think that is what I would do. Dr. Balachander, anything for this question?
Yeah. When in any tumor perforates, basically it completely disseminates into the peritoneal cavity. So the prognosis is not that good. So this patient may have to go a palliative surgery with a adjuvant chemotherapy.
And based on the involvement of the stomach, you need to.
Yeah. We'll have to do a esophagogastrectomy.
Correct. If Dr. Bhargav, if G-junction tumor extended into the stomach, how to confirm the epicenter? See, basically, I guess confirming the epicenter is one thing, but more importantly is what is the proximal and what is the distal extent is more important in deciding what type of operation you do. So basically, whether you can approach it through the abdomen or does it require a transthoracic approach? Secondly, how much of lymphadenectomy needs to be done in the thorax? And lastly, can you use the stomach as a conduit? So these are the 3 questions that you need to ask for any G-junction tumor. So epicenter, is difficult to define in many instances of G-junction tumor. But I feel the proximal and distal extent and involvement of the stomach. So these 3 things are much more important than the epicenter in defining your treatment protocol or regime. Next question is, should we consider a total two-field lymphadenectomy or can we tailor it according to the length of esophageal involvement from G-junction? As lymphadenectomy better stage the disease but doesn't increase the overall survival. Okay, so see, the length of the tumor doesn't really matter. Basically, I think you are talking about the location of the tumor. So if you have a squamous cell carcinoma, the standard is to do a total two-field lymphadenectomy. the abdomen and the thorax part. The third field is debatable. If you have adenocarcinoma, lower third adenocarcinoma, then most people would do an infracardial lymphadenectomy. And the supracardial lymphadenectomy part is again debatable. Certainly not, the third field, which is in the neck, I don't think is advocated for an adenocarcinoma. The next question is indications for wait and watch policy after NACT in esophageal cancer. Again, this is like what we had said, the SANO trial is still awaited. We still haven't come to a conclusion for this, but we will have to wait and see the results. And as of now, the treatment does not change. You have to do a response assessment, and regardless of the presence or absence of
time for meeting.
Type 2-3, can we do a proximal gastrectomy? Proximal gastrectomy for advanced gastric cancer again is debatable. For early gastric cancer, yes, but for advanced gastric cancer, it is still total gastrectomy. For that question, role of transhiatal esophagectomy in lower esophagus, adenocarcinoma. Yeah, again, the approach, still transhiatal esophagectomy is one of the operations that is still in vogue. There is a role for transhiatal esophagectomy, but again, it depends on your, what is done in your center. But
transhiatal esophagectomy is indicated for OG junction tumors, but not for esophagus.
Yeah. So
transhiatal, yeah.
The question here specifically he has mentioned is adenocarcinoma.
Yeah, I know. Yeah, transhiatal is suitable.
Yeah. When you are doing an adenocarcinoma, obviously it also depends on how much of stomach is involved. So it's either an Iverlose operation, or if you're doing a transhiatal esophagectomy, just make sure your conduit is going to be okay to reach to the neck, because many instances your margin should not be positive. Is there any difference in the management protocol for SCC developed on background of achalasia compared to de novo SCC? Again, sir, there is not much literature about it. I think the treatment is essentially going to be the same. There should not be any change in the thing, but in many instances it is late stage when it is discovered. So again, it depends. So I think those are the questions that were there. So shall we conclude, sir? Dr. Balachander, shall we conclude?
Yes, sir. Yes, sir.
Yeah,
sure. We almost addressed all the questions and discussed well.
Thank you, everyone, and thanks, Ravi. You heard all the comments, so I think this is just an exercise where you